You know, the whole cannabis thing is, in my mind, it's absurd. Medical marijuana. I mean, did we call things medical insulin? I mean, seriously, these drugs have so many different pharmacological properties, and yet we're sending people into dispensaries and we're having, kids decide what drug the patient should get. I mean, what do you think?
Yeah, so I'm kind of with you on this one. I've seen the medicinal properties of cannabinoids. But in this country, when you want to use a substance as a drug, we have a Food and Drug Administration. We have a clinical trials process, which is a controlled, randomized, blinded series of studies to show that a drug either has or does not have benefits.
Did you say food and drug, or did you say Fudin drug?
Oh, it's the Food and Drug Administration. That's
the
right.
Food and Drug Administration says no medical marijuana unless it's in a controlled environment.
Can we call it the Gudin Drug Administration?
Food, as well as Fudin's first.
Food and Gudin. So we have a new agency called the Food and Gudin Drug Administration.
There you go.
No, but in all reality, I mean, there are properties of cannabinoids that have analgesic properties, that have anti-anxiety properties, that have anorexic or anti-anorexic properties, and have been beneficial to patients. My biggest problem is I can't support a mind-altering drug in a recreational fashion because I don't want to be driving on the roads with these people. I can support it from a medicinal purpose, but I just don't like the way that it's happened. Like Dr. Fudin mentions, we don't write a prescription for a certain number of milligrams of marijuana. We send them to a dispensary where usually a young person is making medicinal decisions for our patients.
Yeah, and so here's the interesting thing. From my perspective, I look at things pharmacologically, right? So just, it's too complex to break down for this small interview. But, I mean, in general principle, there's two cannabinoid receptors. The one receptor affects the CNS, the brain, the spinal cord, different nerves in the periphery, and the second receptor affects the immune response. So the immune response, that's probably what's helpful for pain, for neuropathic pain, for spasticity, for chronic pain in general. But these other things can cause psychosis and anxiety. I mean, do you have any patients that have chronic pain that have psychosis, anxiety, sleep problems? I mean, so that's where the problem lies, is that these drugs are complex, and you go into a dispensary and you're like, well, okay, so I want to go high, I want to go sideways, I want to go down, I want to be euphoric. I mean, it's just nuts. There's no control.
I will say, and I'll go on the record, that this is really the first year that's a pivot year for me. Forever I've said, there's no way I'll allow my patients to smoke marijuana and get prescription opioids. But the more I see, and I've been using medicinal marijuana for mostly my cancer patients, but some other pain patients, there's a percentage of them. It's not 50 or 100%, but let's say 20 or 25% of them who come back and they've actually either gotten off or lowered their opioid doses. So I'm not against medicinal marijuana, I'm just against the way that it's come out.
I mean, I agree to a large extent, but here's where I have a problem, is that some people may think that it's helpful, and these people may be, as Steve Pasek calls them, chemical copers.
Sure.
So it doesn't really matter. You've got government saying, let's increase the availability of cannabinoids so that we could decrease opioids. These are two completely different drugs. So you gotta wonder, like, if cannabinoids weren't here, would we allow them to sniff glue because they'd feel better? I mean, really, we have people that just, they have to have something, and now I think the buzz thing is cannabinoids. So here's the thing. So here's another example of where people are basically reaching for the stars because they don't know where to turn. So Kratom is available in many states legally. In other states, it's not available legally. It's been outlawed. And there are a number of issues. So from a pharmacological standpoint, I think there's a lot of potential attributes of Kratom. It has a lot of pharmacological attributes that prescription drugs have. It blocks reuptake of norepinephrine. It blocks reuptake of serotonin. It blocks reuptake of dopamine at lower doses. And at higher doses, it has an opioid effect. The problem, again, is that there's no controls because it's a food product. It's not treated as a drug. And so if patients take very high doses, there can be problems. But more importantly, there's a lot of potential for drug interactions. So On the surface, I think that it has a lot of potential benefit if it was pharmacologically prepared by industry and it was somehow controlled and we knew what we were prescribing. But there's a mix that we don't know what % mix it is of this plant or that plant, and I think there's a lot of potential for danger.
Not just potential, Jeff. Reported cases of overdose and death and toxicities related to Kratom, by the way.
Kratom.
Kratom.
Yeah, but I mean, but the thing of it is, I think we've seen a lot with tramadol, right? A lot of deaths with tramadol plus kratom because the mechanisms of action, the way they work in the body, overlap. So you could potentially have a high risk of seizure, serotonin syndrome, even stroke. And these things are not reported. I mean, how would anybody know?
I think what we're both trying to say is, like the marijuana issue, if there's some medicinal benefit to this, it should be studied as such.
Kratom, right?
Kratom.
Okay. Oh my goodness. So I think that cancer patients shouldn't have a free ticket to receive opioids or any drugs for that matter. I can give you many, many examples of people who had their dose raised that the patient was legitimate. The patient was doing nothing wrong, but their caregiver was taking their drug. And so what's the result? Well, the oncologist says, well, there's no limit. I'm just gonna keep going. I'm gonna just keep going until the pain is better. And meanwhile, somebody's selling more drug or getting high.
So I can tell you I've been doing cancer pain for about 25 years. And if we think about the incidence of addiction in the general population being somewhere around 12 to 15%, 12 to 15% of your cancer patients have some addiction issues as well. And they are not exempt from opioid misuse or abuse. They're not exempt from the euphoria. So let's clarify something. Most people who take an opioid feel bad. But if you have that genetic makeup where your dopamine secretion all of a sudden feels really good to you, those are the people we think crave and enjoy the euphoric benefits of opioids.
And don't you think that people that have cancer may even have a higher incidence of substance abuse, or maybe it's the other way around. If you have a substance abuse disorder,
Sure.
You probably have a higher prevalence for cancer because of your lifestyle.
You have bad protoplasm, bad diet, bad genes, those kind of things, and yeah, you might be at higher risk. So in treating the cancer patients, and I can tell you, even in my own community, some of the oncologists have gone away from prescribing opioids. Go to the pain center. They don't want anything to do with opioids anymore because they recognize that 1 in 10 or 2 in 10 patients just runs out early every month, continues to escalate their doses, misses appointments, shows up looking disheveled, and they're like, I don't want to be responsible for this opioid issue. So,
but I'm not to interrupt, but I mean the flip side of that is you got patients that are dying of cancer, and some of them can't get their drugs.
Yeah.
Like, because you just said,
Yeah, absolutely.
oncologists don't want to write these drugs anymore.
Yeah. Which goes back to the whole, you need to individualize your treatment. So when you look at the cancer patient who has no risk factors at all, no history of substance abuse, family history of substance abuse, they're not drinkers, they have no psychiatric illness per se, maybe other than a little depression about their cancer, which is expected, and you do all of the same screening for them, urine drug screening, prescription drug monitoring, there's no reason not to continue to titrate that patient, especially in the face of progressive disease. Right? There's one of the big issues between cancer and non-cancer. If you've had back surgery 10 years ago, you got what you got. If you had a car accident 10 years ago, your pathology is your pathology. But cancers continue to grow and invade into surrounding structures. If you have progressive disease, you may need progressive titration. So I don't necessarily agree with strict guidelines for opioid prescribing in the cancer population, but I think there could be guidelines where you have the ability to titrate in that patient who's appropriate.